Welcome, everybody. Hope everybody's having a great day so far. Welcome to the Community Advisory Council meeting. We are going to start with introductions. Are we doing the land acknowledgement first? Apologize, I still don't have the agenda in front of me.
Yeah, we can do either one. And I just put the link to the agenda packet in the chat.
Thank you.
Yeah.
I had that, but trying to get a physical one. I'm still old school. Let's do the land acknowledgement. Do we have a volunteer to read the land acknowledgement?
We did not this week.
Do we have somebody who'd like to volunteer? Anybody who's present can volunteer to read the land acknowledgement. Just speak up.
Up on the screen for us. It'd be easier.
Yeah.
Thanks.
Brad, if you wanted to allow, there you go. Perfect.
I'm happy to read it.
Thank you. Go for it.
We recognize and acknowledge the indigenous land on which we live, work, learn, play, and grow. This is the land of the Warm Springs, Wasco, Northern Paiute, Tenino, Klamath, Malala, and Yahushkin. We acknowledge them as the past, present, and future caretakers of this land. It is on their traditional land where we partner to improve the health and well-being of Central Oregonians. We aspire to be good guests, honoring the concept and the Warm Springs culture of this land is for you to know and live upon and pass on to the children.
You're muted, Brad. Sorry.
No, thank you. Just a reminder about our meeting practices. With introductions, we generally only introduce CAC members, and that's mainly to save time because we always are running out of time. So everybody else who's not a CAC member, please introduce yourself in the chat. We do our best to use plain language, avoid acronyms, speak in ways that we believe everybody will understand. Don't have to be an insider to understand. We want everybody to feel encouraged to participate and speak up. You can do that either by, typically you could either just speak up or you can use the, what are these things called? The reactions to raise a hand if you're online. If you're on the phone, you're going to have to speak up. I don't know if we have anybody on the phone or not. And just generally be respectful. So let's go for introductions, and I'm not sure who's going to help with that, but either Brad or.
Yeah, I'll go ahead and help with that.
Thank you.
So for CAC member introductions, we'll start with Brad and then Elizabeth.
Hi, I'm Brad Porterfield. I'm the chair of the Community Advisory Council, and I'm a consumer representative.
I'm Elizabeth Schmidt. I'm the vice chair of the CAC, and I got a Mother's Day haircut.
It looks fantastic.
It does. It looks great, Elizabeth.
Thank you.
Next, we'll have Jessica, then Mandy.
Hello, Jessica Jacks. I am with Deschutes County Health Services. Nice to see everyone.
Hey everyone, Mandy Seeley. I use she, they pronouns, and I am a consumer rep in Sisters.
Perfect. Next, we'll have Teresa, then Stacy.
Hello, everyone. My name is Teresa Nguyen. I use she, her pronouns, and I'm with Jefferson County Public Health.
Hi, my name is Stacy Shaw. I'm a consumer representative. I am no longer county representative as I resigned at the beginning of this month.
Thank you. And then we have a May.
Hello, Hi, my name is Amay Maxwell, and I am a licensed massage therapist in Bend, Oregon.
Perfect, thank you. And then am I missing anybody? I think we're good to go.
Thanks, Brad. Thanks, everybody, and welcome, Teresa. I think you're the newest member of the CAC. We're happy to have you with us. We now are going to move into public comments and or patient stories. Is there anybody who has a patient story or public comment? Feel free to speak up. Going once, going twice.
I'll share something.
Okay, thanks, Mandy.
I don't know if it's been mentioned in any of the other meetings, but I just wanted to say that Stacy and I got to meet the new OHA director, a couple weeks ago now, and she seems great and interested in what's going on here, and it was good to be able to represent the CAC that day.
We didn't know that. That was really, would love to hear more at some point.
Yeah, really happy to hear that. You met her. It's awesome. Thanks, Mandy. Anybody else? Give a little bit more space if anybody else wants to make a couple public comment or share a patient story briefly. Okay, well, let's move on. When are you doing the emergent issues update?
I believe so. Just to say that the conversation is coming. We've got the agenda is really built around time with the board around dental. So stay tuned. Don't change your channel.
So you're referring to the combined meeting coming up, Gwen, or?
Yes, we've got a dental next steps discussion coming at 1 o'clock on our agenda.
Agenda and yeah, okay. Thanks, Gwen.
You gotcha.
Okay, CAC members, approval of our notes from the March meeting. The way we've been doing this is if anybody has any corrections or anything that you don't believe accurately represents the way the meeting took place or what the key points of what happened, now's your chance to speak up. Otherwise, we're going to ask for you to or consider that an approval if there's aren't any changes suggested.
Do you need a motion to approve, or is that?
Part of our meeting practices is to not use that system.
Okay, thanks.
Thank you. Good question, Jessica. It is pretty common. Yeah, okay. So the notes from the March meeting are approved. And we'll move on to our first agenda item with Michaela.
Yes, before we talk about raw rip process, I do have a few announcements for the CAC to share.
Oh, sorry, I skipped over that. Thanks, Michaela.
So the first one is to welcome Teresa. She already introduced herself, but yeah, she's the new Jefferson County rep on the CAC. She's the new health community strategist with public health up there. And just want to say that we're really glad that you're here with us and are joining the CAC. And I also wanted to give some space for you if you did want to share something about yourself to share with the CAC. A little about who you are, what you do, interests, anything.
Yeah, thank you, Michaela, for the warm introduction. My role in Jefferson County Public Health is their healthy community specialist, so I'll be doing healthy communities work in terms of like chronic disease prevention, as well as emergency preparedness, and also assisting with their tobacco prevention. So for my role in the CAC, I just hope to amplify the voices within Jefferson County and just, say what we need and yeah, I don't know, just, yeah, fight for Jefferson County and see what we can get for our county. So very glad to be here, and I appreciate everyone being very welcoming.
Thanks, Teresa.
Well, weren't you at previous meetings years ago? I think I remember you.
No, this is my first time in Central Oregon. I was born and raised in Portland, so
Oh, okay.
maybe I have a twin somewhere that I don't know. Let me know. I'd love to meet her.
She's a nurse. She's it was a nurse. Do you remember Michaela?
I don't know who you're referring to.
Oh, okay.
We're glad you're here. Second announcement around that is Christy Rutter, who was here a couple meetings ago. She talked about challenges with accessing the NEMT service. She's applied to be on the CAC. And so we're excited to have her, and she has a strong background in advocacy, especially in the disability space. And so I also want to do just a quick refresh on the process of the CAC application, since it's been a while since some of you have seen this. But when there's two types of members within the CAC. One is, or seats, I should say. One is an appointed seat, and those are the county rep seats, as well as if the Tribal Advisory Council would like to appoint someone to our CAC. Those are the appointed seats. And the other seats are open for consumer reps. And with those, we have, those go through what's called a selection committee, and it's a required committee that the OHA has. And what this committee does is they just do kind of a basic check and make sure that the application is complete and that the applicant would kind of balance out the CAC or diversify the CAC. And so it's that first checkpoint before that application comes to you all to then review and do like a formal vote on approving that member onto the CAC. The last step in the process is that once the CAC approves, then that will go to the board of directors on their consent agenda as that last check off. So there are a couple steps within the CAC application process. Any questions on that? So I guess all of this to say is you should be expecting Christy Rutter's application later this month, early June. All right, next update is around the community health projects. So we pulled together a subcommittee to review the 2023 process. To look at it, review the recommendations that you all gave last November, and to make adjustments to it. And what the community health projects is a grant opportunity that the CAC is in charge of to make social determinants of health and equity investments within the community. And so what this group talked about is keeping the process similar, pretty much the same for 2024 as last year's process. So taking in the pool of funds, which this year is probably going to be around 2 million, dividing it among the counties and the tribes based on poverty rates, having a focus on projects serving rural communities, basic needs, and prevention efforts. Something new that they talked about was only allowing an applicant to submit one application for a county versus submitting multiple applications for different counties. Did I miss anything? Subgroup, subcommittee? Okay. And Brad's going to send out, or he sent out a doodle poll to schedule the next meeting, which should take place into May, June. I'm going to ask Brad to put the doodle poll link in the chat if anyone else would like to join. And then, so we'll meet end of this month, early June, to kind of finalize some details and then bring, draft RFP, the scoring sheets, the timeline back to you in June for that final review of the full CAC before it launches. And Stacy caught that. I forgot about the letter of support. Stacy, do you want to share?
I suggested that letters of support either being required or strongly encouraged, especially for community-based organizations or even county level. Anybody who's claiming to work with someone in that county that essentially the other agency or organization knows that those people are saying they work with them. So I really, really would love to see some updated letters of support and not ones that are 5 years old that are reused every year too.
Yeah. Thanks, Stacy. Okay. Last announcement. Just a reminder that it's that time of year where we survey the CAC to collect demographic information. And this is like information on sex, race, ethnicity, disability, age, things like that. And what we do with this information is we aggregate it all together, and we're able to, this helps us make sure that we are representative of the different communities within Central Oregon. We also have to send that data or fill out a report on that data with the Oregon Health Authority. And so we resurvey the CAC just because sometimes, folks' demographic information changes. And I'm going to ask Brad to put the link to that Survey Monkey in the chat. And just a reminder, this information is confidential. We aggregate that information together before sharing it. Any questions on that? All right, I'm going to pass it back to Brad.
Well, I think just to pass it back to you, Michaela. Yeah, thanks. Are you muted?
All right, there we go. I'm actually going to pass it over to Miguel, and he's going to share kind of the next steps or what to expect for the June 13th meeting with the board to select the priority areas for the 2025 Regional Health Improvement Plan.
You're muted, Miguel.
Okay, thank you, Mary. So thank you so much for having me here today. We are, as you know, these sessions of selecting the topics it's a very important part for the RIP, for the next year RIP, and the CAC is going to be part of this. So we wanted to give you a special preview of what to attend, how to be prepared for what is going to happen in the conjoined meeting in June, conjoined with the CAC and board meeting. So this is the spirit of this short presentation. So next slide, please. So just to remind you where we are in this process building the RIP. So the first case, the first part is nearly complete. So the regional health assessment that you all have as a link. And if you don't have it, we are going to share it with you immediately. So it's really a snapshot of the health and wellness of Central Oregon. This was informed with a lot of information we collect, mainly from the health data indicators that the community survey, the focus groups, community feedback sessions that we did, and obviously the input analysis of public health experts. So this is the first part of what you have to inform that part. On the second moment of this entire process, we did the data analysis. And so we pulled the qualitative data together with the marginalized or underrepresented communities in Central Oregon. And with that together, we create the report that you have in its draft form still, because we are finalizing some details. And then what we are in the moment with we are now is the prioritization process that in this month, during the month of May, We have 3 sessions, one with the Operations Council, the other one with the members of the JEDI, so Justice, Equity, Diversity, and Inclusion Committee, and then also a community group with some members of the CAC that attended, where they are going to make they are going to choose they'll do the prioritization among 10 health topics that came from the analysis in the RAL. So with that in mind, what you are going to do in June together with the board is the next step, which is the selection. So the selection, the board and we are going to make the decision of what and how many topics will go into the 2025 RAPE. So you will be ready to that moment, and this is the purpose of this reminder today to see what you need, what type of support we can provide to you to feel comfortable that day and came to that selection part. Once the selection, so once the board and you decide which of the 10 topics are going to be moving forward, then we will begin to write, to draft the RIP. And everybody's going to participate, members from the work groups that are now, specialists, community members, and everybody who wants to be part of that, to develop the specific goals and strategies, really the plan to move the dial forward. And with that, once we finish that, we plan to have new work groups to implement the plan in 2025. Any questions up to that? I don't see everybody. No questions. Okay.
I have a question for CAC members who are going to be attending the selection process next month. It can bring up different things for folks when folks are community advisory council members or community members to be in a room with board members. There are both real and perceived differences of power in that experience. Is there anything specific that folks can think of now, or they can also contact staff later on if something comes up? Is there anything that as facilitators and staff that we can do to support CAC members specifically to be full and equal participants in that particular room during selection?
I agree. This is Jessica. Thank you for that question. This will be new for me, entering this collaboration with the board. And I think often what I perceive in board settings is some dominant voices getting a lot of the airtime, and a tendency for others maybe not to feel like they can contribute. And I have also observed that your health council's facilitation style is such that you do a really good job of helping everyone be able to have voice. So I think that's one thing that comes to mind, is just kind of thinking about the process, how the dialogue occurs, so that everyone has some opportunity to contribute, whether it's to the whole room speaking, or in a small group setting, or written. But so that's what comes to mind for me.
Thank you for sharing that. And yes, we will be using a wide variety of facilitation tools to both make it more comfortable, but so that folks can participate in the different manners that make most sense to them as individuals. So we're absolutely committed to creating space, not just for all voices, but explicitly for voices that can be less heard in those types of settings traditionally.
And this is the spirit of this presentation, Jessica, to give you a preview of what is going to happen, but also to offer support in a personal way if needed. If any of you feel that you need more time to review the documents or have questions, we can program time to go with you and in order to feel ready for that day. Next slide, please. Thank you so much for the question. Next slide. Yes. So really, what we have on what the materials. This is an idea, a good graph about what the materials have been prepared for you, and so on this entire process, we put the walk-along interviews summary that you can check, the community survey results, the focus groups, town halls, everything go together and advice from regional health experts in the documents that you have, so the preparation documents, together with community feedback sessions that we use to go, we organize a series of feedback sessions to go back to the communities and confirm that the information we collected was representative of them. And obviously the 3 rounds of privatization that I just described. So all that together, the idea is that in June, in this conjoint meeting with the board, you will receive a curated list of health topics to make your final selection. Next slide. So for those of you that were present in the last iteration in 5 years ago, so it was a session that right now it's going to look a little different, because the idea is that you have all the data already, and you are all this information that we show you in the past slide. So it's going to be already selected or already prioritized in order for you to make the selection. But we are going to accompany you through that process. And next slide. And we know that it's very, it feels a lot of responsibility when you come into that moment together with the board to decide which are the X numbers of priorities for next five years. So we want you to make you more, to make you feel that you are covered, because all what we prepare, first you have your lived experiences, wherever community you are representing or you belong. That is a very important asset for this work. So you have close experience of the services, and that is a very important aspect, your lived experience. Then you have all the tools, all the community data that we put together for you, and in order to understand what the situation either for your community or for your region. And we made this with a lot of care in order to make sure that it's pertinent, that is useful for this part of the process. And finally, you are not going to be alone, because in this opportunity that we are preparing in June, you are going to be together with the other members, have opportunity for both personal reflection and discussion, so that it's not something that you will be alone. We are going to be accompanying you all the time. So what do we need? Next slide, please. What do we need to prepare? What do we suggest for you to feel ready and prepare? First is review the regional health assessment that you have, and pass through the qualitative data summary. You don't need to read the entire document. You can focus only possibly in the county you are, or on the topics that you feel that you could be a good advocate. So we don't expect you to understand all the regional health assessment, but at least to check the parts that you want to know. And the same for the qualitative data summary, which is basically the voices of these underrepresented groups that we collected for you, and also use the teachings of Race Forward that has been accompanying us since last month with this idea of getting a better understanding of how to apply an equity lens to this entire process. And so prepare as such, read the documents, request for support. We are here to support you through this process in order to be ready in June to make your final selections with the board and sit comfortably in that meeting and knowing all what is going to happen. So the entire session, the entire June session is going to be devoted to this selection process. We are going to be there, accompany you step by step. But if you need some more support, we will be happy to provide that. Now I'm seeing 3 messages. Oh, okay. So last slide, please. Yeah. So we wanted to make sure that, but everybody already asked that question. So if you have any other question for us, we want you to feel ready for that day.
Miguel, this is Jessica. On the slide with the funnel, you had 3 prioritization processes. I apologize, can you say what are the 3?
Absolutely. Brad, could you go back? Yes.
3
So
rounds, yeah.
yes, so first it was the collection. The upper side is the collection of the information and that we did in the first part of the RA. And then with that information, the first round of analysis, we came back to the community feedback session. So we came to the communities and asked, do you see yourselves in this information we collected? So that was the first part finished. And then all that information during the month of May has been provided to the JEDI group, so to the Justice, Diversity, Equity, and Diversity Work Group to the operation councils. And we also create a community group to make to make a prioritization of this, to put numbers on how important are or how urgent are for them each of the focus groups, to create a curated list that you are gonna have in June together with the board.
So is it correct to think that the third round, the last prioritization process is the June meeting?
No, that is happening right now in May. So in June, you are going to have a curated list with the results of that priority.
Okay.
So
Thank you. I knew I didn't catch something correct. Thank you.
From that curated list, you are going to select now the topics that are going to be in the next RIP. Yeah.
Thanks.
Another question?
Yes, Miguel, this is Linda. I apologize for signing in late. I wanted to ask what process did we go through to select the community group that will help with the prioritization? So
the process that we made in May contains basically a representation of the areas that we considered that would inform, because they were accompanying us through the entire process. So obviously the Operation Council was very important to have that vision of the specialists, right? And we also request the support of the JEDI because they have this vision of equity, and they have been helping us to design the values and identify, as the CAC, identify the communities that we needed absolutely to collect information from. And then what we add together with the CAC is that we also open the door to the community members that identify themselves during the feedback sessions that they wanted to support and continue to be part of the process. So we made an invitation, an open invitation. People who wanted to be part of that, and we integrated that together with the CAC members. Yes. Did I answer your question? I think.
Yes, and open me up for one more.
Sure.
Just to, so people who volunteered through your outreach, great. Were there any populations that were not represented in the respondees that we would need to fill in for? For example, seniors or another group that doesn't have representation in the prioritization conversation?
Yeah, we took a lot of emphasis on trying to balance or direct the invitations in a way that we don't have only, for instance, Bend residents, but we have a balance. And it was the same among the communities. So we have representation of the seniors, we have representations of ethnic minorities, etc. Yes, we were very careful during the entire process to create a balance on that. Yes.
Great. Thank you so much.
You're
Yeah,
welcome.
I'd like to add to that. 2 of the prioritization sessions have yet to happen. They're happening next week. But for each of the prioritization sessions, we have taken demographic data of the respondents. So when we have all of that information done, once the actual prioritization sessions are finished, we could give you more detailed information about that.
Thank you, Avery. That's a very good, important note. So we have, that's the reason we are collecting this data. Yeah.
Gracias, Miguel. Thank you for that. And thank you, everybody who had such great questions. I do need to do a time check and move us along. If there's anybody else who has any input on that, please use the chat or reach out to CAC members or Health Council staff. Our next agenda item, we have Tasia back with us. So Tasia, I welcome you to take the lead.
Thank you, Brad. And is it okay if I take a full 30 minutes or do you need me to shorten it all?
Go ahead and take 30 minutes. I think we'll figure it out. Yeah.
Okay, thank you. Nice to see you all again and some new faces and names as well. My name is Tasia Ahuja Smith. I go by she, her, and hers pronouns, and I am the director of training at Race Forward. I came to join your meeting last month, and I've also been meeting with the board over the last 4 or 5 weeks, and with the wonderful COHC team to think about how to support some of those tools that Miguel was just talking about, putting those in your toolbox and shoring up that work that y'all are going to be doing very soon. So today I wanted to do a part 2 of what we did together last time, and I'm going to pull up my slides just to sort of map where we're going. We're going to do a bit of refresher just on what we covered last time. And then I wanted to save some time for us to actually get to practice with some of the questions. So we are going to do a breakout where you'll get to do some application work. And then we're going to come back together into this full group to do a little debriefing. But that'll be our half hour, and I'm watching my clock, so I keep with the half hour. Jumping in on the refresher, I think and you all can see my slides, okay? Okay, great. One of the key concepts that the team asked me to bring and that we thought would be helpful as you're considering all of this input and thinking about the prioritization work that's coming up is the race and framework. And this is a framework, as a reminder, where we want to talk about race explicitly, but not exclusively. And what that means is we're looking at a lot of intersections. So we know that people show up with many identities and from many communities. We have folks who might experience different things at the intersection of race and gender, at the intersection of race and immigration status, race and class, race and age, race and whether they live more rurally or more urban. There's a lot of different ways that these sort of areas of our identities, particularly marginalized identities, can show up for folks and can really impact our abilities to access healthcare, our abilities to be able to survive and thrive in our communities. And so that's one big concept we wanted to share, is thinking about this as a lens through which we can really consider how different approaches might impact communities in different ways. And one of the ways we did that, we looked at this as a quick image. The content itself isn't as important as just pulling out sort of when we look across different lines of identity, particularly along lines of race. And one of the reasons why we at Race Forward often focus on it is because there's a lot of sort of disparity that shows up that persists from historical factors and current factors today. And this was one example that we quickly touched on. But I don't want to spend too much time there because I think the big question that we came away with, or the big idea that we came away with also, is this idea that when we are thinking about solutions that work for the people who are most vulnerable in our communities, we often are able to find solutions that actually work better for everybody. So this idea that sometimes is called targeted universalism, where we want to help everybody thrive. And in doing so, sometimes we can come up with better solutions to do that if we get really specific about the disparities that people along lines of race, along lines of gender, all of those sorts of identities that are marginalized in our society experience. And so we did a very quick walkthrough last time of 2 examples. The general sort of universalist, let's help everybody by giving everyone the same thing approach. We talked briefly about this example from California, where they had great intentions. They wanted to help everybody. They infused a bunch of money into the system, but because they didn't do a great job on the front end, sort of thinking about how that might impact, for example, rural communities or low-income communities where teachers might not want to stick around and they might move to the higher income districts where they could get a better paycheck, for example. The good intentions actually led to a negative outcome, particularly along lines of race and, family wealth and those sorts of things that you might expect. The other example we looked at was the city of St. Paul, where they did do some real deep consideration when they were thinking about wanting to expand the level to which community was accessing and using the library service that they were providing. They took this targeted universalist approach, or really thinking about how do we really plan our solution around the disparities that we know exist along these lines? How do we really target folks who are most impacted? They thought about people who were getting most often barred from using the library because of fines and fees. And they decided, it would be a great solution that particularly helps that group, but also improves everybody's sort of quality of interacting with the library, is just to get rid of fees for everybody. So this was our counter example of finding a great solution for all based on focusing on those big disparities around income and race and historical factors in this case. I have one last slide of refresher, which is we talked about asking some different questions in order to be able to apply that lens to really think about as we're designing solutions for our community, as we're prioritizing solutions that are necessary for folks to survive and thrive, which is the outcome that we want to get, asking some different questions with a specific racial equity lens can really help us get to better solutions. And so last time we went through a whole bunch of questions. This time we're actually going to get to work with some of those questions to with some real life information, some real life data from the qualitative data summary that Miguel mentioned from earlier. So we're not going to you don't have to have these questions memorized because we're going to work with these questions, some similar questions. I'm going to give them back to you. But I am just going to pause there and see if folks have any questions about that's our refresher on sort of what we did our first go around. Any questions or thoughts that might have occurred to you since we talked about this last month? And if there's any place it would be helpful to go back to also to get a little more information. All right. I'm not seeing questions, but we can always come back if something occurs to y'all. as we talk about our application practice. Do we feel good about moving into application? Thumbs up or like a little wave? Thumbs up. Okay. All right, I see some nods. That's excellent. So what we want to spend some time on today is doing a little bit of application practice. We're going to actually practice, as I mentioned, by looking at some real data that came out of the qualitative data summary. Avery, thank you for pulling some of that out. I think it's really helpful to actually consider some of these questions in context of some of the real data that you're going to be, that has gone into all the things you're going to be considering next month. So also thank you for that great funnel visual, Miguel. That was really helpful for me to see as well. The first thing we're going to do together, I'm going to ask for 3 readers because we have 3 different little paragraphs on a slide that I'd love us all to hear. We're going to read through that together. Then we're going to split out into some small groups. And I also have what we're going to read written in a document that I'll share so you can look at it while you discuss. But we're going to split out into small groups so you can talk with each other about what are the factors that are going on here, given the information we're getting from this subset, this selection that we pulled out of the qualitative data from the community, and given some of the questions that we talked about to help us apply a racial equity lens. What are some concepts? What are some ideas? What are some thoughts that you have? What are different perspectives that might be coming up from this data and from asking some of these different questions? You're going to get some time on that. And I think we can probably take, let's say 8 minutes. I think we can take 8 minutes in those small groups. Brad is going to help us get there, but first we're going to do the reading part all together so that you all can discuss, you can try it out. And then we're going to wrap up by coming back together in this main room to do some debriefing, to talk about how did that go? Did it inspire any ideas for y'all? Do you have more questions after having tried to work with this tool a bit about how to get more out of it? And that's how we're going to spend our time together today. And I just want to add a big reminder that there's no perfect answers, right? What we're trying to get to is not some magical solution. We're going to wave a wand and solve all of the issues that folks have with healthcare access or with having great services or any of the, intersecting problems that can really damage our health outcomes for our communities. There's no perfect answers. They're very complex challenges that we're trying to make progress on improving, right? The goal here is to just practice. And I think the important part of the practice is this slowing down to really sort of pull apart what are all of the pieces under the surface here? What are the nuances? What are some different perspectives that are hidden away maybe in this data or outside of this data and how we might consider this topic, so that as we're trying to think about our decisions, our solutions, in this case, the decisions you'll ultimately be making is that prioritization of where resources will go for the RIP. But it's really for us to just practice that, including more perspectives, slowing down, really getting into the nuance and the context to hopefully make even more informed decisions for our communities. So we're going to move on to reading a few of these, if that feels good. And our health topic that we're digging into for this example is access to and quality of healthcare. So I'm going to need my first reader. Feel free to come off mute and read this here for us. And maybe I can get go ahead, Jessica. And then if I can get 2 more folks who want to raise their hand for the next 2 slides.
Okay, so I should start from the very top.
Yeah, that'd be great.
Okay.
Thank you.
Data on community needs, access to and quality of healthcare. Black community members indicate that we must increase diversity in the backgrounds and identities of providers. We often don't see ourselves reflected or feel understood when we seek care. Alongside this challenge, they say, we recognize a severe lack of access to care, including insufficient appointment availability, denied services, long wait periods, uncertainty about how to access specific services, lack of preventative care, dental services, other treatment services, and even availability of ambulances.
Thank you so much. All right. I need a second reader and a third reader waiting in the wings.
This is Miranda. I'll read this one.
Thank you.
All right, so data on community needs, access to and quality of healthcare. At the same time, Spanish-speaking community members indicate that we have experienced discrimination, language barriers, and lack of understanding of our culture when we try to access healthcare. We might cancel our appointments due to these bad experiences at clinics. Moreover, due to the severity of mental illness in our community, we need in-person sessions with the therapists who can understand our language and culture.
Thank you so much. All right, our third and final reader. One more person who can help us.
I can volunteer for this one.
Thank you.
LGBTQIA2S+ community members throughout Central Oregon state that we demand healthcare providers who reflect our lived experiences and are trained in up-to-date, evidence-based practices for the unique needs of LGBTQIA2S+ people. This includes, but is not limited to, gender-affirming care for adults and youth, behavioral health, obstetrics, gynecology, and more. Moreover, we need clinics, organizations, and providers willing to reach out and be vocal in the community. They should clearly offer these types of care and stand by and protect their patients, families, providers, and employees from prejudice and hate.
Thanks so much, Brad. So these are three small windows into some information, some data that was gathered on this topic of access to and quality of healthcare. And we are gonna have a little bit of practice with this concept of asking some different questions. I'm going to list the questions up here, but I'm also going to share you a document that has the blurbs and the questions in them, so you don't have to memorize them or write them down. You'll have that to take into your breakout groups, but just to cover them together. The first one, who benefits or who else could benefit from focusing on access to and quality of healthcare? And for a question like this, it's helpful to get specific as you're brainstorming together. Who do you mean? What communities? What identities? What locations are you thinking of? Who has been historically and or currently burdened in regards to this topic? Who might be burdened by selecting this topic? What are root causes and contributing factors to the current situation, which is some poor access to and quality of healthcare as reflected in this data? What patterns of lack of access to power might be involved? What policies or practices are currently contributing to the experiences of inequity that we're hearing from these communities? And thinking about all those nuanced pieces, contextual factors you're considering, what health topic priorities advance equity around race, gender, sexuality, language, immigration status, economic class, geography, and more when you think about the information we just heard? So again, the goal is not perfection, it's just practice. There's a lot of questions, there's a lot of information to consider. No wrong answers. The hope is just that you can have a good discussion with your small group. I just put a document in there that you should be able to open up to be able to see the blurbs again and these questions. And there's a place actually where you can take notes for your group if you would like. You don't have to. It's just, we're gonna have about 8 minutes in our practice groups. So if it's supportive to take notes, feel free to take notes. If it's not, feel free to just look at the blurbs. But I'd like you to use these questions to guide your conversation and see what emerges, see what new perspectives come out or what new considerations you might bring to making a decision about this topic as you work on applying these questions. Do those instructions make sense to folks? Any questions before I will ask Brad to help us by breaking us out?
So just as a reminder, during selection, you're going to be choosing some, but not all, of the possible health topics that we could focus on as a region. And so the questions are framed in such a way that if we chose to focus on this particular health topic, knowing that we can't focus on all of them, but if we focused on this one, access and quality around healthcare, and then kind of going through the questions from there.
Thanks for that reminder, Ivory. All right. I know that Brad has been helping us set up these breakouts. Thank you, Brad. Awesome. And I think we're actually going to maybe shorten it down a little bit so that we make sure we have some time to come back together and debrief at the end and not get off schedule. But I'm looking forward to hearing where y'all go, what nuances you explore, and I think we can open the rooms. Welcome back. I see a bunch of folks just popped back in. All right. So I know that that was not a lot of time at all for a very deep topic, but I'm very interested in using a little bit of time just to debrief what it felt like. What went well in your conversations? Did you have any aha moments, or maybe any place where you were like, oh, we really had a rich conversation about this thing and I would love to have another 25 minutes just to talk about it. Let's hear from a couple different groups. Oh, Elizabeth, I think I see you, but I think you're on mute.
Okay. Well, we had a good conversation. It was too short. We just talked about, see, my son-in-law is Spanish, one of my son-in-laws, Jose, and he teaches high school kids Spanish, the English speaking. And of course, my grandkids with Jose are, you know, Spanish. And I just said, I'm used to having to speak. They speak in Spanish a lot around me. So, but they're great cooks too. So we didn't get too far. We talked about Molly Torelli. She's with Pacific Source, and Jeff is with Pacific Source. And I have several Black friends, so we just got to that and we were cut off. So that's what we did.
Thanks for sharing. I know the time is short to get to have shared context with each other too, for how you want to think about pulling out some of these different perspectives from different communities. I think I saw Linda, and then I saw one other person who came off mute. I don't know who it was, but let's hear from Linda and then.
Well, our group really talked about how we've all taken a great first step on translations. And then the thought occurred the second step would be understanding that not all people and not all cultures obtain and access information the same way. So that we really need to involve the groups that are not involved now to say, yeah, it's great having a translation. This is how we hear on the radio versus reading, or as an example, so that we can make sure that the message we have in the right language is transmitted through the proper means.
I love that. Thinking about how we can go a level deeper on inclusion once we figure out, okay, we know there are some needs here, and if we were to prioritize this, there could be more resources here. I think someone else who didn't have video on had come off mute at one point.
Tej, I'll jump in. This is Brad, if nobody else.
Thanks, Brad.
Jumping in, yeah. So my group was myself and Stacy, and kind of off the top, the topic seems too broad to me. access and quality of healthcare seems to be pretty much everything. So that's a separate issue though. But in general, it seems to have a universal benefit because if you're focused on access and quality of healthcare, that should benefit everybody. If we target that effort toward those who have the least access now, I think we all believe that by every more people having good health benefits everybody. So there's universal benefit, but then if we target it, we can have more benefit for those with the least access. There could be a burden on providers in the sense that they may not know how to create welcoming spaces for more, for diverse employees. Once they hire them, there's that issue or that challenge. They're going to have to adapt in one way or another. Maybe they don't have, the money. They can't afford to hire new staff. Who knows? But there's providers are going to face some degree of burden to adapt to doing a better job at serving a broad, diverse community. And I'll stop there.
Thanks, Brad. I really appreciate that. I think when the topics are particularly so broad, getting to the level of specificity of thinking about, okay, providers themselves are a group that are going to have to, sometimes there's positive impacts, sometimes there's negative impacts of strategies or solutions we might be trying. And it's not a bad thing to put those all out on the table and then to really think about, to your point, what is that sort of universal community benefit we're trying to get to by really focusing in on the places where we know there are most disparities. So I'm appreciating the specificity too, Linda, of what you brought up of just getting to specifics, I think always helps us to make sure that we're not forgetting communities. It can spark more ideas as we think about those specifics. And so I wouldn't shy away from that. I'm just gonna pop up one last slide to close out. Which is, we did some of these debrief questions, but I really just wanted to bring back our race and idea, which I definitely heard in some of what y'all were bringing up. Bringing up race as a frame to make sure that we're thinking across a lot of lines of difference within our communities that we know exist within our communities while we think about benefiting everybody as a whole, and thinking about the places that intersects. So even in some of the blurbs that we read, right, there might be intersections between the LGBTQIA 2S+ community and the Spanish-speaking community and the Black community and the low-income community. All of those identities can show up for communities at once within communities, and they're connected to us, right? So I am really grateful to have gotten this time to work with y'all ahead of you thinking about how to grapple with these really big topics in the prioritization session that's coming up. And I hope that bringing some of these questions, having these tools in your toolbox will help y'all as you're having the conversations when you're going to really need to weigh sort of how are we going to decide one priority to cut or two priorities to cut to get down from this list of 10 into a more narrow list. I hope that this can really enrich your conversations. And I think I'll leave it there unless Avery, you have anything else you'd like to share to close us out.
I think that's wonderful, Tasia. Thank you so much. And we'll be sending out their packet of materials at the end of this week. So you'll have plenty of time to review not just the data, but there will also be guiding sheets of information about some of these topics. We recognize that, what we've been able to do over the last several months is just a short dive into highly complex things. And so we want to be able to give you some really like functional, useful tools that you can use as you go over the data before the selection date. And as always, us as staff is always available to support you in your preparation.
Thank you, Tasia and Avery Grace. Appreciate it. Yeah, apologize that our time is so short. Be great to spend more time with you. But I think it's benefiting us, it's raising our awareness and giving us some things to think about. So let's go and move on to Michaela, who's going to take the lead on our discussion around dental.
All right.
Like this.
All right, so this is a follow-up from our conversation last month. And so with our time today, I wanted to just real brief refresh on the background. We also have some updated grievance and appeals data to share with you. And then what I really want to spend most of our time together is to talk about how we would like to spend our time together with the board of directors in June, because we were able to get an hour with them to discuss dental access in Central Oregon. So just to refresh on the background, y'all have been working on this for a couple of years now, and it started with quite a few CAC members sharing their experience and difficulties accessing dental, and then more specifically periodontal care. And with that process, you've engaged the board of directors by sharing patient stories. You also had a meeting with the dental care organizations, the CCO and the Oregon Health Authority, to kind of get to like, what are those system level barriers that we're both, we both have poor experiences in with this, and coming together and identifying those root causes. And throughout that meeting, some of the things that you all identified were the low reimbursement rates of dental compared to commercial. But there are a few, or that the need for more dental care providers to serve OHP clients. And also in that meeting, it was shared that there's only 35 periodontists in the state of Oregon and only 2 in Central Oregon, which presented some challenges. And so with that information, you wrote letters to the Oregon Health Authority's Health Evidence Review Committee, or the HERC, the Medicaid Advisory Committee, as well as the HERC Oral Health Advisory Panel. Last fall, you met with the board of directors, and you and the board agreed to develop a process to work on emerging issues together. I'm going to skip over that slide. And so that's kind of where it's left off since this fall. Currently, we know that dental access is still an issue. We know CAC members are still expressing difficulty accessing dental services. Some other things that are happening is that we heard that the Health Evidence Review Committee, their oral health advisory panel, is currently looking at reimbursement rates, so that could be an opportunity for the CAC. Pacific Source has taken some actions in improving dental access, which is Kristen is going to share a few. And we know that the RIP Oral Health Work Group has recently opened up a grant opportunity to increase dental access. So there is some work happening in Central Oregon. And we know that you and the CAC, or you and the board, still want to work on this. However, it's been a challenge to kind of get you and the board together. However, there is an opportunity in June for an hour to discuss this, which we'll get to looking at the time in just a couple minutes. But before we kind of move on to that piece, I just want to give Kristen an opportunity to share the data that she came that you asked for last month. Sorry, I'm trying to cram all this large discussion that we had planned into just a few minutes with you that we have today.
Hey, Michaela, do you happen to have the PowerPoint I had sent over this morning?
Yep, one sec.
If you wouldn't mind just sharing that first slide, then I can kind of read the key, which is on the second page. So it's just hard to toggle between. So if you go back to the first page, sorry. Okay. So we wrapped up the Q1 2024 grievances and appeals, and the team pulled out dental grievances. And so Rihanna had put together a few slides just to sort of look at the trends. So access complaints about offices being difficult to contact and or not being able to schedule. At the board meeting last week, Dr. Allen from Advantage Dental had shared that the Prineville Advantage office had a flood and it was closed for many months. And I actually think that might be the only dentist in Prineville, but that takes OHP. But Elaine, if you're here, please correct me if I'm wrong. You might know. When I was still out there, they were it. So that impacted availability a lot. And you sort of see that in that first bar labeled number 7 on the chart there. So that correlates to access issues, those first 4 colors there along the bottom. And oh, sorry, what does that say? Can you move your cursor? Wait, 7. Oh, there was 7 total, and then A was provider's office unresponsive, not available, difficult to contact for appointment or information. So that was 3 of the grievances. So that's sort of how that chart works. Kind of difficult. The second bar there was 2 access complaints about, what does it say? Sorry. Oh, unable to schedule appointment in a timely manner. And then the other access complaints were unable to be seen in a timely manner for urgent/emergent care and verbal denial of service by provider. So those were sort of the access complaints that we received in it with dental. The next category, CR, stands for consumer rights. In the complaints, we received 3 total. Does that say 3? 4? 3, 4. But those were around member dissatisfaction with treatment plan. And the examples were not involved, didn't understand, choices not reflected, not person-centered, disagrees, and so forth. Fraud and financial abuse, which I thought was kind of interesting. And then provider bias barrier. So the examples were age, race, religion, sexual orientation, mental/physical health, marital status, or having Medicare/Medicaid. And then the last complaint under consumer rights was complaint/appeal process not explained, lack of adequate or understandable NOA. Oh, notice of appeal, I think is what that stands for. And then we had interaction with provider or plan complaints, which those were wants to change provider not a good fit, provider rude or inappropriate comments or behavior, plan rude or inappropriate comments or behavior, provider explanation/instruction inadequate or incomplete, plan explanation/instruction inadequate or incomplete. And then QC is quality of care, and that was received appropriate care, but experienced an adverse outcome, complications, misdiagnosis, or concern related to provider care. And then that last category, QS, stands for quality of service, and it was delay in receiving or concern regarding quality of materials and supplies, which is durable medical equipment, or benefits not covered. Does anybody have questions?
Thanks, Kristen. If you don't mind, I'm gonna move us
Yep.
along. We have only 5
Oh,
more
I'm
minutes.
sorry. Did you want me to share really quick a couple of things that we're working on, or later?
Yeah.
Okay. Super fast. Pacific Source is bringing a dental van to our office in Bend to facilitate oral health evaluations for members with diabetes. Heather Simmons and Dr. Ash, who's our dental director, are attending the Health Evidence Review Commission's Oral Health Advisory Panel, and that meets again on May 29th.
Thanks, Kristen. All right, so that's just a little snippet of things that are happening currently. And what I want to move us to is next month, we have an hour with the board. One thing that we want to propose to you, the CAC, is to make a specific request to our board of directors, like a formal request of them to stand up an ad hoc committee to come up with recommended actions. And so this would allow, you with them to kind of pull on the different levers and strengths that you both have together and really have a space for focused and concentrated effort on this. For our time in June, this is what we have outlined and want your feedback on, is if you're in agreement and on board with asking the board to stand up this ad hoc committee. We would want to start out our time together with a local expert like Christian Anderson Moeller, who's been involved at the state level and also involved in our RIP work groups and kind of understanding the system level barriers and from that perspective. And then also asking CAC members if you have any stories you'd like to share with the board on that more personal, powerful level. And then kind of coming in with that more formal ask to get a committee stood up. Thoughts on that?
Just, Michaela, one thought I had, and it's sort of coming out in an awkward form. CAC really focuses on Oregon Health Plan recipients.
Mm-hmm.
And I'm wondering if there's additional data that could be gathered either as a part of the RIP process or as a part of the specific dental access conversation with the board about complaints or grievances, or are there other populations that are experiencing the same thing that OHP clients are receiving? Is there data from other insurance plans, or is there a data collection at the dental plan level? I'm not even sure what available information there is, but it would seem to me that if there's a shortage of dentists, for example, that would affect others. And if we find out that in fact it's only affecting the OHP population, we'd have very different strategies.
Yeah, so what this ad hoc committee could do is look at that data and kind of really dissect it to find those health disparities and really focus efforts on that, addressing those.
So Michaela, the question is, would this be an approach for our 1 hour we have with the board next month? Would be to have a local expert come and do some level setting with a CAC story, and then go to the board with a formal ask to set up an ad hoc group to take some action or make some recommendations. Is that the ask of this group right now?
Is the ask of this group.
Is that hitting the target, folks, or is that off target?
CAC members, do we want to do a 5-finger vote on that? CAC members? Just to make sure we're all together on this? Do you want to repeat that, Gwen? I mean, I think it's right there in writing, but.
Yeah, I'm looking for some feedback. I know there's a lot of silence, and some folks are off screen, which is fine. But I think as staff, we're trying to prep for a meeting that's about 4 weeks away, 3 weeks away. And so wanting to figure out what we have available, and see if this is near to the target that you are looking for as CAC members around the time together with the board to try and move it forward. So if something in the chat or thumbs up or down or sideways, it's like, it's good enough, I guess we'll take it, but we want more, or this is great, it's a good first step, or no, staff, go back to the drawing board, I'm going to give you a call later. All those are great options. So please, speak out, come off mute, give us something to work with.
We have our 5-finger voting system, so let's use that. Mandy, I see your thumbs up. Do you want to throw out some fingers too? So 5 is absolutely 100% support. 1 is no, I don't support, and then basically only a 1 is a no. A 2 is a we need more discussion. I'm not super comfortable, but 3 and up is just a gradient of your support. So we're using the chat. Okay, let's do that. It's looking good.
Awesome. Thanks, everyone. I'm sorry this was so rushed and a little bit scrambled at the beginning, but I'm glad we got this piece, and we'll prep for our June meeting with the board.
Yeah, thanks, Michaela, and everyone who's involved in this. Let's go back to you, Michaela, for the community health projects update.
So I gave that update in the beginning of the meeting. So I don't have anything else to add for that piece.
Okay. Well, let's, I mean, we do have 10 to 15 minutes left. I just want to open it. What's that, Michaela?
Our meeting that typically ends at 1:30, and I know on the agenda it said 1:45. I just want to make sure that everyone has time to stay if we wanted to continue conversation.
I guess we just say people are free to leave if you need to. But if you do want to, because we were kind of rushed on almost every topic, if anybody has anything to say, anything you want to share, any questions, we could do that now. Any questions?
I don't have a question. I just wanted to say I feel I appreciate the dental conversation, and also feeling challenged to contribute to it because I'm new and you have so much history. So I am intrigued. I think it's really I'm supportive of the direction that's been taken, but I just been feeling challenged to contribute further until I have a little bit more background on that. So just wanted to share my 4 response and lack of input.
Thanks, Jessica. Anybody else?
Well, I had a question to Mandy and Stacy. When you met with the head of the Oregon Health Authority, did you all discuss dental at all?
I brought it up, Elizabeth.
And what happened?
Well, we didn't really have a conversation about it. And I left before Stacy did, so there could have been further conversation after that. But we just did, Stacy and I both, well, Stacy did like an introduction and about her experience on the CAC. And I just mentioned that one of the challenges of Central Oregon was our lack of periodontal care and access to dental care. And when she was like reiterating what she had heard throughout everybody, because it wasn't just Stacy and I, there was a ton of people there. She did mention that and said that they were looking at it. So we didn't get any like definitive answers or anything, but she's aware of the issue at least.
Did she mention about her director of dental that hasn't been hired yet, I guess? Did you mention that?
Not while I was present, Stacy. No.
No, I don't think so. It was like a conveyor line of, hello, this is who I am. Let's talk really fast about something in 2 minutes to sum up my entire experience.
Oh.
Yeah, I brought up that sometimes resources can get I don't want to say trapped, but can go to one area and not dispersed more evenly, and that I really enjoyed the community projects last year where we were trying to be more creative with how we allocated the funding that we got, and that you know, basically there was a lot of positive feedback on that, and I think it's really important for the communities to steer what's going on in their area. And yeah, so yeah, 2 minutes conveyor line of information. So.
And she was also meeting with other providers the day after, so it's possible that she had some conversations with some dental providers, but we weren't there for that, and Dustin was there.
Yeah. Hi, everyone. This is Dustin. I can say that the search for the OHA's dental director is ongoing, so no decisions there.
If we have more time together, can I bring us back to the dental piece with the HERC and the oral health advisory? So the Health Evidence Review Committee, which is the committee that kind of looks at different benefits and sees whether or not they're like going to be a benefit, which is covered or not covered, kind of above or below the line. So I heard that they have a meeting recently to look at dental reimbursement rates. And their next meeting is at the end of the month. So I think the 29th. And so I was wondering if the CAC would want to kind of write another letter to them.
And I'd add that there's also another overall meeting of the Health Evidence Review Commission on June 10th, and you can submit, you can sign up to give verbal kind of testimony as well. Oh, there it is. That's perfect. There's another one on the 10th, so that might be another opportunity too, if you can make them HB9.
Do either one of those have an online option, virtual option?
Yes,
Yes.
they're all virtual.
Are you guys able to share those with us?
Yeah. Wait,
Okay.
Michaela and Bradley, were you guys going to send that out? If not, I can put I'm not sure if this is going to have people register for the meeting, but I can drop it in the chat.
Thanks,
Yeah,
Kristen.
we can share the
So
page.
I have the link as well too.
Okay.
Is it reasonable for us to request information from the Oral Health Advisory Committee on what efforts have been done to increase provider supply or to try to solve some of the issues and points that we've raised before?
I think that's reasonable, and it certainly goes back to kind of the rate reimbursement and incentivizing individuals to, continue to provide services in the state, specifically rural areas. So yeah.
You.
For you all, how does that writing a letter to HERC, how does that land with folks?
I think it's a good idea, actually.
Okay. Dustin, Kristen, so the oral health group is meeting on the 29th and there's another group meeting on the 10th. Which one would be the best one?
Specifically the oral health, if you're talking about dental, that would be much better. But if by chance you just need other topics and want to bring it to the entire group, because there's multiple subcommittees of the Health Evidence Review Commission, so it doesn't hurt to try and touch both. But yeah, I also dropped a link to kind of just the website of the overview of the HERC for you as well for reference.
And can I just request that maybe we get this in an email, all the stuff that's being shared? It's kind of hard to,
yeah,
at least for me to deal with. Right?
I'll make sure it's handled.
Thank you, Brad.
Yeah, we can send out this information and then we can also send a draft letter for folks to input and add stuff to or edit.
Fantastic. And Dustin, I couldn't understand you. Did you say the HERC might be better if we had to choose one? Or did you say the other one?
Sorry, I was saying that the oral health committee, if it's on the 29th, would be better because it's specific to dental, but that's a subcommittee that focuses on those things. But the overall HERC large group, which is on the 10th of June, it wouldn't hurt if we by chance don't make it in time. So include that as future topics.
Got it. Thank you. Okay, folks, anything else anybody wants to share? I did have a question for maybe Miguel, but probably just the Health council staff in general, have the raw and the data summary, has that information been shared with the CAC already?
Yes, we send an email with yes.
The data summary and
yes, but we can send it again. We send the materials. Well, it has been shared in the past, but we are preparing a new email with the materials that you are going to have, and we are going to send it this Friday. Yeah.
okay, fantastic. I just want to make sure we all have plenty of time to attempt to digest it.
Yes.
Yeah, gracias. All right, well, last call for any commentary, questions, comments.
Brad, can I ask a question about the data collection again?
Yeah.
Maybe a tiny bit off subject, but also not. When talking about providers and diversity and being able to increase just providers in general, is anybody asking folks, whether in college, out of college, or just in the community, did you want to be a doctor? What were your barriers? What prevented you from doing this? People who are or who are almost providers in whatever health realm, just asking them some feedback on things that were hard for them, just to see if we can maybe get more insight in that realm.
No, does anybody have any feedback on that? I know there was the workforce board, along with healthcare providers like St. Charles and others were, and probably Pacific Source. I don't know exactly who all was involved in that, but Miguel, you were involved in that, I think, maybe others. But they had put some effort into the whole workforce question and all the challenges and so forth. So maybe there's data that they hold that could inform that. Anybody else have information about that?
So
Stacy, are you thinking of just dental providers or all health providers?
All health providers, kind of, for me, understanding maybe work environment, maybe figuring out if there is some gaps in some of our health systems where it's not a welcoming environment for some of these marginalized populations. Is there a greater issue than just money? Because I can tell you, you can pay me as much as you want, but if I'm not happy where I work, I'm not going to stay. So I wonder if promoting or encouraging workforce, not workforce, but corporations, agencies, organizations, whatever it is, to have a more welcoming environment for diverse providers to want to work there.
I think it's worth asking a question of the major providers here in the area. Are you collecting any data currently? And if so, what information do you know? Is there any Oregon specific data around specifically health manpower shortages, and what are the reasons for that? I know there's national, you can get a ton of national resources that can look at that, but I think what I'm hearing is more specific. It's what's national may or may not apply here.
Miguel, you were going to speak up. Do you want to have the last comment before we close out?
Sorry, just because you named me, I was there at the beginning of that commission a few years ago, but I don't know where they are. But I can reach out to the responsible now, because the idea, yes, that was to improve the problem with the providers, with the number of providers on different areas. So, but one of them was oral health. I will ask and send you the information.
Okay, thank you. All right, good questions, good comments. Thanks, everybody. We'll see you next time.